Medications for opioid use disorders in correctional settings. Shifting the paradigm, creating a balanced correctional and rehabilitative approach. The Opioid Response Network is funded by SAMHSA to provide resources and technical assistance needed locally to address the opioid crisis. This video is part of a series to provide guidance on the implementation of medications for opioid use disorder in correctional facilities. Leading corrections and behavioral health experts present information on topics such as the use of medication, models of delivery, diversion, and linkages to care and community support. Jennifer Clarke and Leslie Bridgman discuss operations.
Our initial goal was to, and I said this morning, screen everybody. We learned very quickly that just asking the question, have you used opiates, was getting everybody that needed to be on MAT, and we referred everybody for an assessment. That doesn't mean everyone who said they used opiates started MAT, but they were referred for an assessment. And we had the three major populations that we were looking at were people that were coming in and continuing. The one population is people coming in that are already on an MAT program. We just wanted to continue those individuals. People are coming in and withdrawing from opiates. We made the MAT program available to those individuals. And for people who are about to be released, we also wanted to make MAT available for them. And our goal was to have seamless transition into the community as well as comprehensive MAT services, so the counseling as well. This is our facility. It's 6 buildings on one campus. We can walk to everywhere. There's no one's getting sent upstate, and that has made it a lot easier for us. So there are considerations that you might need to take into account in your facilities that we haven't. All of the medications are dispensed from the men's intake facility. They are packaged up and couriered to the other facilities. And we have providers on site 5 days a week and offer comprehensive services.
So we were really trying to focus, when we were thinking about this presentation, what the most important policies were in terms of getting an MAT program up and running, as well as policies that we had significant barriers to and really kind of lessons learned that we wanted to convey to you. So we've broken them down into 4 subjects. I'm gonna go through them really quickly. The last 2 presentations, we didn't make it to institutional and administrative considerations because we were allowing questions, but again, the slides will be made available. So this is a brief overview of what we want to touch upon. So access to opioid treatment services, that really is your starting point when you're looking at beginning this program. And so I kind of have 3 questions that I think really are important before you start writing your policies. And so first, start thinking about how will patients continuing on medication from the community be continued on the inside. Think about how that process is going to look. And then start thinking about how will individuals be referred to that program. So think about those that are coming in not on medication or are currently in the Department of Corrections. How will they be referred? How will they be told that they can send a medical request slip for the program? And then once you've got that referral process down, then what? What else are you going to do? So this was our vision. We thought it was going to be this really clean, neat process. We really were focusing on the intake, the committing process to be that starting point. And we, as Dr. Clarke alluded to, is we were going to, we wanted to use the TCU-5. It was, a validated instrument. We imagined that we would have a clinician that was down in the committing room that was going to be providing this screen to offenders as they came in, and from there we could, assess their needs, and if they met criteria for opioid use disorder, then we could start kind of this whole process, and that's where we really envisioned it, and this is our reality. So we, this is what has been working for us, and what we really wanted to kind of convey is that it's not a clean process, and you need to go with it. We accept referrals from all different areas, as you should as well, and as the best way to capture the patient population and those who need treatment. So this is some of that small font that we talked about. This is taken from our actual policies. Again, all of this will be made available to you. What I want to highlight again is how our process is for continuation patients coming into the department that are on treatment in the community. We use that DOC nurse at commitment to really send that referral to our CODAC staff. So here, something that's a little different is we operate with two different EMRs. The DOC has all of the medical, dental, mental health, and then our MAT services, clinical, medical, everything is incorporated into the DOC EMR. The CODAC EMR that's located in our dispensary that's inside the Men's Intake Service Center is used only for inventory and dispensing of the medication. So what happens is that when a medication is confirmed by the DOC nurse, an inmate registration form is completed, and that essentially just has the basic information needed to create a patient profile in CODAC's EMR. So anyone that we're dispensing medication for has a patient profile, has a patient ID number with CODAC, essentially making them a CODAC patient. So that form, along with a printed out copy of the prescription from the DOC EMR, is faxed to the CODAC dispensary. So we always need to make sure that both EMRs have the same information in terms of prescriptions. Again, it's tough with a lot of paper being faxed back and forth. There's always room for error. The new induction referrals, again, looking at trying to get individuals when they're committed, when they're likely going to be in withdrawal. We use the committing nurse again. What I tried to include on the bottom was just an example of what that referral process looks like. So the EMR has an order manager, and we are considered an on-site specialty, MAT therapy. So someone comes in and reports opiate use, the nurse just clicks and sends that referral to MAT therapy. They can provide a clinical comment, as you see here, but they also don't need to. We've tried to make it as simple as possible for the nurses. So some challenges and lessons learned, again, we touched upon. The biggest thing is don't reinvent the wheel. The nurses were already asking individuals if they use drugs and alcohol. They were already asking that question. So it was really nice to not have to make, add additional work to them. We were able to save a clinician having to be down in the committing room, which saved, we were able to, allocate those services to patient care. Security was happy because we didn't have a clinician down there. We saved paper with the TCU screening. Again, there's always challenges integrating two EMRs, especially if they don't talk to one another. So that's something you want to be aware of when you're thinking about that system, especially if you're working with a vendor. And Dr. Clarke touched upon this in the morning, is consider the implications if patients transfer to another jurisdiction. Consider that with people that are coming in on the medication, it's a conversation you want to have with them. Also consider it before you start someone on it, especially if they're not in withdrawal. You want to be very aware to not have individuals that have gone through the withdrawal process, you put them back, on medication, and they go to a facility where they just have to go cold turkey. In the beginning, I believe there was an incident where an individual, a female, had actually transferred to a facility where that happened, and when she had gotten out, she had overdosed. So the next policy we wanted to touch upon was counseling, again, highlighting that this is medication-assisted treatment. It's not medication. We, on the clinical side, know that we need to provide counseling. It's a federal regulation. We also know it's good patient care. It helps, to address those, the behaviors and the thought patterns. I will say on security's end, security really appreciates this component, that to explain that patients are not, are required to attend a group to actually work on these behaviors. It might be surprising, but security really appreciates that. So for them to know that it's just not a medication that they get every day, that they actually have to do kind of this work on the other end really does go a long way. In terms of curriculum, I'm really going to, kind of merge the two here. You want to look at the varying patient needs. I definitely think that sentenced patients versus those that are awaiting trial will present you with different needs. So you need to make your curriculum to meet those. So again, you want to view patients as kind of like your customers and give them the best experience. So in terms of awaiting trial patients, we struggle with not knowing when they're going to be released. So we're always preparing them for that unexpected release. And a discharge planning group is a way that we're able to provide kind of an overview of discharge services for those that are potentially going to court that don't believe they're going to get out. But again, there's always that chance. In those discharge planning groups, we talk about, one, community resources just at a very general basis, clothing vouchers, local shelters, local places, for mental health or any, how to get an ID. But we also really do focus on, should you get out and it's not planned, this is where you go, this is who you call, this is the plan that's in place. And we really try to ingrain that in their head so that, again, they get out and they have seamless transition. The nice thing, again, kind of going back to CODAC, having, our EMR on the inside is they have patient IDs, they're CODAC patients. So an individual gets out at court, it's not expected, and that appointment hasn't been made for their buprenorphine provider. We dispense Suboxone, it's buprenorphine and methadone in the community, so that individual essentially knows they can walk into any one of our sites and not have to worry about, well, I don't have an appointment. It's a simple, I was a patient on the inside, and they know they can get their medication, and that's made a huge, huge, huge difference. Try to go quick. Some challenges and lessons learned. Establish clear expectations. Patients are going to try to push the limits with counseling. It happens out into the community. So have in your mind, have guidelines for what is considered noncompliance with not attending groups, and what are you going to do to manage that? Understand and also probably educate the security staff that this program, MAT groups, is different. There's a medical component to it. It's medical treatment. So, it shouldn't necessarily be lumped into any policies the facilities have with other programming, that the discharge policies should be different. And I think that's something that's going to save a lot of frustration if you can address that. Spacing is always an issue. It's something, again, just to be very mindful of, that not only do you need a room, but also make sure it's a room that can hold enough patients in it. Make sure that it's not a room that, there's can only be, 5 individuals. So here again, we've got some language pulled right from our policies on discharge planning, which I've talked a little bit about, and this morning we had talked about. But what I want to do is I want to talk to the challenges and lessons learned with discharge planning. And again, all of this really should be thought about before the program begins, and that's something that we learned. Understand the current reentry services that are already happening, because chances are is that there is someone doing substance abuse discharge planning services. If a facility has a few patients that might be on buprenorphine, someone's obviously working with them to help continuation. When we first started this, there wasn't that communication component, and we had some people that were coming out with 2 appointments for Suboxone providers because there was no communication, that the discharge planner didn't know that they needed to no longer provide that service. So really reach out again and communicate and figure out what's already being done, and then establish clear kind of standards as to who's going to resume services, who's going to provide this service, because chances are is what happens is with communication you can almost probably divide up the work. Develop those strong relationships again with community providers, even if you decide to go the route of a vendor. Again, so CODAC we have locations throughout Rhode Island, but we don't hit everywhere, and we don't expect patients to stay with us. So it makes it much easier when we have points of contact at our other local OTPs. It makes it a lot easier, especially for your awaiting trial folks, when you need to squeeze them in with only a day's notice. I can't stress that enough. Like I said, in making the effort to go out to them as opposed to having an email or a phone call. Start slow. Be very, very careful of starting people on medication that are awaiting trial if you do not have a plan in place, to a point where essentially if someone gets out and it's not planned, where can they walk in and continue their treatment? That needs to be something that's absolutely kind of set in stone before you take on that risk, because again, you're setting people up for failure. And transportation and insurance, we know, are just continuous issues.
And so this is my cheat sheet to get everybody on the same page. It's for the 3 different types of medication and the 3 populations. So for people who are continuing on medication, one thing I changed was I capped the buprenorphine at 16 milligrams. Doesn't mean we never go up, but the providers have to ask my permission. And part of the reason we did that is I think a lot of people were coming in on 24 milligrams that didn't really need 24 milligrams. They may have been sharing, selling, and we had quite a few people who were on too high of a dose then. Also takes a long time to dissolve 3 strips. So we capped it at 16. If somebody needs more, the clinician just gives me a call. And it's actually only happened twice that people have called to increase the dose. Most people are feeling fine. I get plenty of patient complaint letters, so I don't think anyone's shy about complaining to me if they have a problem, and I haven't had any complaints about that. The methadone, we continue at the dose they were on in the community. And the naltrexone, we switched to oral while they're in, and we'll give the injection right before they get out. The inductions for new patients, I won't go into the specifics, but we go pretty slow. We go even slower for people who are pre-release, so people who have not been on an opiate. We'll go very, very slowly with them. And please feel free to interrupt, ask questions at any time. If somebody's going to a different state or is being transferred off-site, or they have a sentence that's longer than 4 years, we do a taper, but we do that very slowly. It's over usually 4 to 6 months that we taper somebody off their treatment. And we do dose evaluations after the dosing. One of the advantages of having an MAT program in our setting is we'll see people hours after they've been dosed. They don't have to hang around and wait for us. And the officers are usually more than happy to share if somebody's nodding off or there are any other problems. One thing I forgot to mention, aliases. A lot of our patients come in, didn't use their real name the first time they came in, got married, changed their name. Our system doesn't usually keeps them under the first name that they've been in. So there's often a discrepancy between the community and our name and date of birth that we have on record. So we've come up with a process to resolve that, with having photos faxed back and forth, having a confirmation from the community clinic on what they were taking on the outside. Another issue, I just wrote down some issues that I forgot to put on slides. With the groups that are done, there's no good time for participating in those classes. So with our anger management, they'll usually get 4 or 5 days of good time, so time taken off the sentence. We just made sure that this is a medical decision and it's not related. We don't want it to be related to any security benefits, because there would be some incentives maybe to be on the program that wouldn't be beneficial to the patient. Issues of diversion, that we had a lot of questions about that in our last few groups. One thing that we learned early on was, as a new medical program director with this program, I said, you know, whatever security wants as far as the timing of the medication. They chose 9:30 p.m. for the dose of the medication, which I just didn't even really think of. And that became a huge issue. People were up all night. The medications can be very energizing. Everybody thought it was better. The security thought it would be better at night because they thought it would help people sleep, but it was a bit of a mess. And it took us about a year to work with security to get them all changed to morning Medline. So now all of the medication is given on first shift. So don't make that mistake. The other issue is contraband. We didn't have, security just marks in their system, which is not in our EMR, yeah, but they have their own electronic system. They'll just mark things as contraband. And what happened was there's this misperception that everybody was diverting buprenorphine. But they ended up putting in new codes, and I suggest you do that earlier rather than later. So not only do we have that a medication was diverted, but whether or not it was MAT or a different medication. And that really helped with a lot of misunderstandings. At first, they did just a medication diverted, and it ended up that most of that was not MAT. You know, could have been Benadryl, but it was, people had the perception, security had the perception that there was a lot of MAT being diverted, and once we cleaned up that system, it really helped out a lot.
There was a lot of belief, there was the belief that gabapentin is part of the MAT program. So a lot of those diversions were for gabapentin. And you know, we still work on that. Every once in a while I'll get, you know, please address this. But as we know, gabapentin is not part of the MAT program.
And then the other issue that I should have worked out earlier with the union and with security was toxicology or urine drug screens. Security, I'm told often, is, you know, there's a HIPAA waiver for corrections. Not true. If there's a security issue, then we can disclose information, but urine's drug screen is not, you know, it's not a clean slate to disclose the results. So I should have discussed that with security. Instead, security found out we were doing the urine screens, which I did tell them we were doing, but that they weren't getting the results. What we do now is we tend to do them in parallel. So they will test everybody on the program. We do not also give out the list of who's on the program, but there are separate med lines. It's the same way we don't say we have, you know, diabetic insulin med line. We say it's pre-meal med line, so that it's as close as we can get to protecting somebody's confidentiality.
Medline 2 is
Medline 2.
Medline 2. People know that is usually the line for methadone or buprenorphine at that. We really thought with toxicology that we could just say, but see, regulations tell us we have to do it, so like we have no choice, and we kind of thought that would let security, all right, we get that they really got to do this, but it was, yeah, it wouldn't even matter if we just wanted to do it just to kind of make things difficult, or there was a regulation. It still was, they wanted that list of who's on the program, the results of every urine screen.
And so I think that's, one thing, had we done it earlier, we would have had a smoother ride. So I think I went through most of these.
Question for you.
Oh, yes.
With regard to administering the medication, you want to be able to efficiently administer the medication in a way that is, satisfy your security staff, so there's minimal diversion, but also in a way that the patients are okay with it and they feel like they're not spending a lot of time in that process, and they feel like it's professional and they're comfortable with how they're getting it. Do you feel like you've worked those?
So the question was about how we give medication, and are the patients comfortable with it? And I have to say, each facility has their own system, and we had to do. And we had to do a lot of educating around that, because somebody would go from intake to medium, and there the medication is given at a different time. They do pretty thorough mouth checks, so I think not. Some people don't like the buprenorphine as much as the methadone, because they have to wait the 20 minutes for the buprenorphine to dissolve. Whereas with the methadone, they just take their dose, drink some water, and then they can go in for lunch or whatever it is for the different buildings. Mm-hmm. Do you have any other comments on that?
I think something that I know is happening now was, in the beginning, patients felt very rushed with the buprenorphine process, and that led to some, suspected cases of diversion when we ended up finding out it was. So there was the education component that, yes, do most patients, it dissolves in this amount of time, but you need to understand that if it could take individuals longer. So now it's very accepted practice that if a patient needs longer to let the medication dissolve, security is going to let them have that time. And I think that's helped with a lot of the, again, the diversion. But I think if you can see here, it's really building specific. We try to, the medication they try to dispense in the medical area when they can. When it's outside of the medical area, really that's just due to the numbers. So for example, the buprenorphine at Men's Intake Service Center, it's the awaiting trial building, could have anywhere from 55 to 65 people on buprenorphine at any given time. There's nowhere to fit that many people, so they use the dining hall and are actually challenged with that. Versus, women's, they dispense both their medications at the same time, and the only space that, didn't have anything going on was the visiting room. But again, for the most part, they do try to use the medical area because, again, it is private.
So I'm trying to see from I know we think about it from in terms of how long it takes for us as staff to get all the patients through the medication dispensing process, but from the patient standpoint, okay, I'm going to get my medication. How much time out of their day would it take? I know I'm supposed to get it at 7 a.m. Do they get hung up, and could they end up losing an hour of their day waiting to get the medication?
So so the question is about the sort of inconvenience, if you will, for the patient, and generally it's not something that people have complained about. It's a little bit of extra time. I think mostly people are happy that they're getting the medication.
it does not interfere with programming. So we've adjusted some of the times because because it led to, for example, at maximum security, we had it, I think it was earlier than that, and it interfered with one of the core programming, which again, now we've got people choosing between medication or programming, so we adjusted it. I can tell you that buprenorphine at intake, they need to have everyone medicated before court and before breakfast. So breakfast starts at 7:35. So, I mean, maybe people are in there for 30 minutes, but the way that they tend to have, some of the systems is that they let people kind of go as, I think there's actually videos. I would recommend really to see any of the videos that ORN has on their website, because it shows you kind of the process. But again, we were very cognizant that we didn't want to interfere with anyone's programming.
Thank you.
Yeah, we definitely had to make that change so that people can go to work. So minimum security, people get the medication before they go to work. So there's, we had to make certain changes to make sure we're not interfering. And for the occasional person, if it's 30 minutes and they don't like waiting at the table, we've had a few people who've requested changes to methadone because they feel like it's faster, but it really has been pretty rare that people want to change.
This just kind of goes into all of the factors that go into the med administration, and that they really all do kind of blend together. Something that I wanted to point out that we didn't have the chance to do it in the other presentations was when you're looking at time, we're talking about time, especially like what works best for the facility. Obviously, we know that morning is the best time, but also factor in the time to prepare the medication. So something that we struggled with was we found the time at 7 o'clock, but the courier came at 7:30. So now we're asking the dispensing nurses to to prepare 50 more doses. And again, these are not medications that we want nurses to be rushing. So you have to factor in, not just that time, but also the time it is for the nurse to prepare that medication, even if they're coming up to a window. Factor in that component as well. Staffing, I would look at on both sides. Staffing it's gonna be more security, it's gonna be more nursing on both ends. And then the type of medication, it's very easy to, I think, implement a med line for methadone because most of the patients can just go right up to a window, drink the medication, and then go, versus security is not going to be happy with someone, taking buprenorphine and then just going, that they're going to have to make a dedicated, that's going to spend more time. And then the projected patient census, again, kind of, are you going to have a facility, our high security facility, we haven't really ever had to focus on is this a good place to dispense the medication, because our numbers historically have always been low there. We've never had more than probably 3 people at any given time, versus, in a medium security facility, we know the numbers can grow. So
We touched on most of that. One other issue with the staffing is we needed to hire 2 RNs to do for just the medication for 350 people. So that was, it's a big part of the budget. But if you don't have the staffing, you cannot safely administer the medication. Mm-hmm. And that's 2 nurses, 7 days a week, which once I became medical director, that was 3 FTEs that I had to move around. And there were issues with the union, what can CODAC do versus what does the union do? So if you're working with the union, make sure you have those conversations early and often.
So some institutional considerations. We haven't even gotten to this in the other ones before. Scheduling, something to be aware of is, again, if you want to accommodate the specific patient populations, an example I'll give is a work release program. You certainly don't want to be taking patients out of their job one day so that they can go and they can sit in a group at 12 in the afternoon. So we had to make the arrangement that we have a clinician that runs groups in the evenings. So that's something that you want to be aware of. I know in Massachusetts, one of their work release buildings, they said it needs to be on the weekends. So when we were talking about hiring staff, we were like, all right, we need to find someone that's willing to work a Saturday. And the same thing with provider time. So it's, we have a provider on site Monday through Friday. There are 6 facilities. So we're constantly trying to kind of get the most bang for our buck. We're not going to send our provider to a facility when there's one dose eval that could maybe wait until next week when there's more patients to see. When the women's center had 3 commitments that came in the night before that are sick and in active withdrawal. So you, again, want to kind of look at that. And again, we're lucky because they just need to get in their car and drive. But other facilities, I know Massachusetts has had conversations about, are you going to have someone drive 30 minutes? And we all know in corrections, depending on if, your level of clearance, to get through security can sometimes take 10, 15, 20 minutes in itself. So again, I always try to say when I'm arguing for more provider time is, yes, I get that she's scheduled for 8 hours, but she's not seeing patients for 8 hours. It's, and security might be very slow moving patients. It might take someone they see a patient and then they're sitting there waiting 20 minutes until the next patient's brought up to them. So those are things that you need to be very aware of. My recommendation is always overestimate the amount of provider time you're gonna need. Medication movement, something that people didn't think about is, especially if you've got a vendor if you're going to have an OTP that's co-located on the inside, you want to make sure that you're safely moving that medication to the areas where the patients are receiving it. If it's leaving that dispensary and going out to other buildings, you certainly don't want a nurse just walking with thousands of milligrams of methadone throughout. It's something that DEA is going to look at as well. For example, there's no inmate movement when the medication is moving outside of the dispensary. The medication is moved out of the building through a stairwell that only the nurses have access to. Our courier is bonded and insured. So you want to take be aware of that. The space, again, the diversion piece we had touched upon. Restrictive housing. Again, you want to just make sure that you might have individuals that are in restrictive housing for prolonged periods of time. They'll still be getting their medication, but you also want to make sure that they are getting some kind of a clinical component. I think it's sometimes easy to forget that it's, this person's been, is in restrictive housing. I'm not going to put them on the group schedule. And next thing you know, it's, been several weeks. So again, you want to remember how you're going to address that. Are there better times to see these individuals? It's important, and especially because you don't want to forget that population. I went over the weather component, but again, it's something to be aware of, depending on if you have a contractor. So for example, if the state is closed because of weather and they require essential staff, our nurses that dispense the medication are contractors. Do we have them come in? Do we have them pre-pour medication in advance for weather-related issues? And I think in some administrative considerations, and I know Dr. Clarke can speak to probably some of the financial component, think about the record keeping in the EHR. Are you going to have a paper record? Or is the record going to be electronic? Are you going to use 2 different systems? the staffing component, but also I think I'll hit on the relationships, that this cannot work without having the trust and respect of security. I tell people that even if you can manage to make it work, you're not going to retain staff because it's going to be a miserable working environment. So that's something that needs to start from the get-go. You need to hire staff that have a level of emotional maturity, that can understand corrections. We are always telling the staff, reminding them that we are guests at the DOC. As vendors, we are guests here in a place where safety and security are right front and center. And so you need to have staff that can understand that and can understand kind of that give and take, and that respect needs to be earned. Because again, you'll make it work, but it will not be happy. It will not be a good environment.
Technical assistance is available to support the evidence-based prevention, treatment, and recovery of opioid use disorder. To request technical assistance, visit opioidresponsenetwork.org.